Eva Maddox. That's pretty easy to pronounce. I don't have
Eva, like whatever.
I apologize, Eva. I was mispronouncing your name. I should have clarified that.
Yeah. Eva? All right, Eva. And then I have another speaker I'm hoping to clarify how to pronounce their name, and I don't know if they're here yet. Our second talk, Wentao Li. Is that pronounced correctly?
Yeah, it does not look like they are here yet.
Okay.
I think I'm gonna admit.
Srikant, we have Sarah and Brandy, so I'll introduce Sarah Henderson and Brandy Wiltshire. Is that correct? Okay.
Yeah, that's correct.
Thank you. And then the last one is Phan. Phan? Is Vu here?
Yes, yes, that's correct.
Vu, did I say it correctly? Phan or Phan?
Phan, yeah, Phan. Yeah.
Thank you.
So if anyone hasn't practiced or tried sharing their screen to make sure that it works on the presentation, we can do that. We're about 3 minutes out here. We're still missing a handful of speakers. Trying to make sure that we have anyone who might be on the author list so that we can, in case there was a swap in speakers here. Okay, we're still missing a couple speakers. Oh, there we go. There's one. And another one. Okay. I think we have everyone except for one speaker in now. Let's see. So Tiffany, we have all of the first 4 speakers, right?
I'm waiting for Mr. Li to correct me. Wentao Li, the second presentation.
Okay. All right, and Antonia, do we have all of the next 4 speakers in here? I believe we should.
Is Ross here?
Yeah.
Yeah, I'm here.
Okay, great, thanks. We have Mike.
Ross, would you mind sharing your screen really quickly to make sure that it works, and then renaming yourself to be the number, I believe you are number 5, so a 5 period, and then your name.
And I know I'm probably repeating myself here, but I'm not sure everyone was in the session. Once you share your screen, a pop-up will appear. Before doing so, just make sure you click the optimize for video. And if you're looking to share sound, make sure you click the share sound box, both on the bottom left of that pop-up.
Can you see that?
Yep.
Okay. The next speaker is number 7, Onbeshnik. Just joined, I believe.
Yes.
Okay.
So while they're here, and it is 9 o'clock here. So I'm going to ask. I'm just going to quickly make sure that we are pronouncing everyone's name correctly. Do we still don't have our second speaker? Is that correct? Onbeshnik, is that how you how do you pronounce your name? I want to make sure you're muted. Hold on, let's change that really quick.
Onbeshnik is co-host, so you should have the possibility to unmute yourself if you just go to the bottom left of your screen and click the mute button.
Can you hear me now?
Yes.
Okay, so my name is Onbeshnik.
Okay. And Gaspard, I apologize, that might be incorrect. How do you pronounce your name?
My name is pronounced Diotalevi.
Diotalevi?
Diotalevi.
Diotalevi.
Yeah.
And did I pronounce your first name correctly, Gaspard?
Yep, it is.
Gaspard Diotalevi.
Yeah, I won't take offense if it's a little bit wrong,
Okay.
don't worry.
I will do my best. I apologize if there is a mispronunciation.
No worries.
And I believe we have then everyone. We're still missing one speaker, but we can go ahead and get started here, and we will, since it is 9:01, have the other speakers join as we let everyone else in.
Are you okay for me to disable the wait room function, Peter, and we'll begin the session?
Yes, I think Antonia and Tiphanie, we have everyone except for 2 speakers. Is that correct? Oh, I think I have yes, so let's go ahead and we should, I think Virginia is one more speaker that we need to, let's check. Virginia, are you presenting the anticipatory cues abstract? Okay. So then Virginia, would you mind renaming yourself to be speaker number 9? And we need Virginia to have co-host privileges as well.
Speaker number 9. Okay, I will.
Yeah.
How do I do that? Sorry.
So if you go into the participants tab, you should be able to click on your name and click rename.
Okay.
And that will help. And then we can go ahead and disable the waiting room, and we'll get started here. We're running a few minutes late, but that's expected in the first session here. So
Perfect. I'm going to unmute myself and turn my video off and then disable the wait room when you can start.
okay, perfect. Okay, welcome everyone to the Posture and Balance Rapid Podium session at virtual ASB 2021. We're excited to kick off the first podium session here today. We're running a couple minutes behind schedule, which I think is acceptable given the first abstract-based talks here. But we're going to structure this session. There are a total of 12 different talks. We've separated these into 3 blocks of 4 talks each. We're going to have those presenters present one after another. So each presenter will present for about 5 minutes. We're just going to go straight into the next presentation, and we've reserved a block of time of about 10 minutes after each block of 4 talks for question and answer. So as you have questions that might pop up, please enter those into the chat, and we will moderate those and ask the speakers those questions during that designated Q&A time. So my co-moderators here, so I'm Peter Fino. My co-moderators are Tiphanie, Raffegeau, and Antonia Zaferiou. And we'll be kind of splitting the moderating duties here. But I'm going to turn it over to my co-moderator, Dr. Raffegeau, who is going to introduce the first 4 speakers in this session.
Hey everyone, good morning. Welcome, welcome. I'm very excited about our first session today. And I'm also really excited to introduce our first talk, where we're going to learn about the evidence of using a dynamic maximum normalization method for muscle activation during a weighted back squat. And so I'd like to welcome Eva Maddox, please.
All right, can everyone hear me okay? Yes, good, okay. Hi, I'm Eva Maddox, and I'm a student in the neuromechanics lab at Old Dominion University. Today, I'm going to give you some information about normalizing electromyography. Measuring muscle activation is an important part of what we do as scientists to understand how the body is able to overcome gravity and in some cases, extra weight like a barbell. Everyone has different levels of electrical signals going through their muscles as their bodies move. We measure these signals with sensors on the skin known as EMG. In order to compare 2 or more people to each other, we have to normalize the data by dividing it by a baseline signal. There are multiple techniques for obtaining a baseline maximum effort measurement that are frequently used by researchers. Of all available techniques, isometric and dynamic maximums are the most frequently implemented. An isometric maximum is collected at a well-established optimal muscle length for a muscle of interest. In this case, we tested the biceps femoris, whose optimal angle is in the prone position with 30 degrees of knee flexion and a neutral hip. Normalization of muscle activation patterns during externally weighted tasks often result in activations that far exceed standard maximum isometric recordings. Also, maximal loading is required for full activation of muscles in order to complete the back squat, which could suggest the use of a DMBC is more applicable normalization scheme for EMG signals during weighted exercise movements. A dynamic max method involves a subject performing the maneuver being studied and taking the peak activation from the target muscle during that movement. In this case, we had our subjects perform a 1RM back squat protocol and use the maximum number obtained from the biceps femoris during the upward phase of the back squat as our dynamic maximum. There is debate out there on which technique is better. The consensus for experimental design in electromyography or SEED project says to use the maximum dynamic contraction whenever available. They recommend this because the isometric contraction has substantial limitations for tasks like squats to full depth, as they tend to extend far beyond postures generally involved in MVIC collections. Currently, there is no universally adopted method for normalization of muscle activation during weighted exercises, likely due to the mixed results from previous comparisons between each scheme. Our study aimed to compare reliability and variability of biceps femoris activations during sub-maximum back squats when normalized to standard MVICs and activations during a 1RM squat. After collecting both a 1RM measurement and an MVIC measurement from 27 participants, 13 female and 14 male, we had each subject perform an 80% 1RM back squat. We then normalized that measurement to each of the 2 techniques. When we look at all 27 subjects with each of the 2 normalization techniques, we see a 3 times greater variability in MVIC compared to DMVC, which means the isometric normalization technique is far more variable than the dynamic normalization technique. We also found the MVIC and DMVC have similar levels of reliability using interclass correlations. Additionally, as a female strength coach, I am always looking for research showing me how females are similar and different from males. And unfortunately, not enough is done in exercise science separating out males and females. As such, we looked for interaction effects for peak biceps femoris activation. And we found sex differences were larger in females when normalized to the isometric than to the dynamic method. This makes inter-study comparisons tricky when normalization techniques vary. Therefore, caution is warranted when compiling results from multiple EMG studies. Based on our findings that DMVC was as reliable as MVIC and that DMVC presented with reduced within-group variability, we suggest EMG should be normalized to a dynamic maximum contraction, especially for weighted exercises.
Great, thank you so much. That was a great talk. I really appreciate it. I can't wait to ask questions when we get through our next few speakers. Our next speaker is Wentao Li. Are they in the audience? We haven't had the chance to connect with them yet. Okay, we'll go ahead and go to our next speakers then. And we'll come back to that talk if we can. So we're going to jump ahead to speak from students from Elon, and we'll hear from Sarah Henderson and Brindy Wiltshire as they talk to us about the effects of dual tasking on force production during a 5-time sit-to-stand task in healthy young adults.
Alrighty, is everybody seeing my screen okay?
All right. So hi, my name is Brandy and I have Sarah here with me. We are Doctor of Physical Therapy students at Elon University. And today we're going to be talking about the dual tasking and the 5 times sit to stand task. So the sit to stand task is a task required for independent daily living that is commonly transferred into the clinic as the 5 times sit to stand task assessment. And this is typically used to assess functional strength and power in several populations. So there are multiple phases of the sit to stand task, but we chose to focus on the concentric and eccentric phases. So research has shown that there is a certain level of cognitive demand that is required to perform transitional movements, such as the sit to stand task. So the purpose of our study was to examine the effects of a concurrent cognitive task on the force production during the sit to stand task in healthy young adults. And we also hypothesized that the dual task performance would show more variability than the single task performance. So for our study, we recruited 10 healthy young adults with a mean age of 24 years old, and they were all asked to stand up and sit down 5 times as fast as possible. They did 3 trials without a cognitive task and 3 trials with the cognitive task of counting backwards by 3. And so for our dependent variables, we measured peak force, impulse, and power, which were all normalized to body weight. And then we also calculated their total time to complete the 5 times sit to stand task. An average and coefficient of variation were also computed, and a one-tailed paired samples t-test were used to analyze data. And if you look over here to the right, we have a picture at the top of our standardized setup. Feet were positioned on the force plates and no upper extremity help was used. And if you look down at the graph here, you can see where we analyze the concentric and eccentric phases of the sit to stand task.
So once we analyzed the data that was collected, we found that there were clinically significant differences from the single task trials to the dual task trials in 2 of our variables. The first variable being the time to complete the task, in which we found that it took participants a significantly longer time to complete the 5 times sit to stand task with the addition of cognitive load, and that paralleled with a decrease in power that was produced during the 5 times sit to stand task as well. And so our healthy young adults did take a significantly longer time to complete the 5 times sit to stand task, but this was done without altering their peak force or impulse, but rather by lowering the rate at which the force was actually produced, as seen by the power variable in the previous chart. And since this task is a functional task indicative of lower extremity power, this may provide some insight as to how cognitive load may play a role in completion of this task and how it may be more difficult for other individuals to perform compared to other various populations. What we did find was that there were consistencies in which the force, impulse, and power were produced and how that was unaffected by the demands of an additional cognitive task, as seen by the coefficient of variation in the previous. The elements that we would like to highlight is that the 5 times sit to stand task is used to assess fall risk among various populations in the clinical setting. And so we hope that this research can serve as a foundation to look into further populations with various conditions and assessing whether or not other populations may be at risk for falls as well, based on the cognitive load of the tasks that they're performing. And so what we want you all to take home is that using dual tasking during the 5 times sit to stand task could have clinical utility, and it does have the potential for being a more sensitive measure for measuring lower extremity power in several populations and various conditions. Thank you very much.
Thank you both, ladies. That was awesome. Way to split a presentation that's challenging and in the era of Zoom, so bravo.
Thank you.
We'll go ahead and move on to our next speaker, our final speaker for this block, and then we'll get the chance to ask these guys questions. I'll also encourage you to please go ahead and use the chat to allow us to sort our questions out at the end of this block. So our next speaker is Phan, who's going to tell us about intermittent switching rate as a measure to assess impacts of Parkinson's disease and a secondary task on postural balance. Take it away.
Yes. Yeah, so I hope everyone can see my screen. Okay. Yeah, so good morning, everyone. Thank you very much for having me here. My name is Phil and I'm a student. Today I will present our preliminary work on applying intermittent switching rate as a measure to assess the impacts of Parkinson's disease and the secondary cognitive test on postural balance. So first of all, PD has been known as a major cause of chronic disability. Moreover, in daily activities, it is not uncommon that people, including people with PD, do cognitive tasks while standing, and this kind of dual tasking can further decrease the ability of maintaining balance. And that's why it is important to investigate the standing balance, especially the standing balance of PD population under such a dual tasking condition. And recently, several studies have developed the measure called intermittent switching rate, which is the measure of the discontinuities in the motor control. The authors reported that the reduction on the ISR represent severe deficits in the underlying motor control that help us to maintain the balance. So this measure might not only be maybe applicable to the clinical assessment, but also help to enable the explanation of the postural balance in relation to the function of the central nervous system. So that's why in this study, we investigate the impacts of the Parkinson's disease in the mild to moderate population and the secondary cognitive test on the intermittent switching rate. So for the experiment setup, we recruited 27 subjects in total and we had subjects performing the quiet stand test on a split belt treadmill, each foot on each side of the treadmill. So the COP under each foot was recorded by different platform, different force plates. And the subject were asked to wear the earbuds, which was used to transmit the stimuli of the auditory strip test in the dual tasking setup. And then subjects were asked to perform two single test trial followed by two dual test trial. Each trial was separated by a quick break. This one is the data the analytics pipeline that we use for the data processing. So for the pre-processing step, we first filter the data with 10 Hz low pass Butterworth, and then we compute the net COP followed by the calculation of the resultant distance for further analytics. And for the computation of the ISR, further detail can be found on the reference 1 and 2. But our final purpose is to get the instantaneous frequency represented in the time frequency domain, like you can see in the figure here. Then we apply a threshold, which is the red line here, and count the number of spikes above the threshold divided by the trial period, which is 50 seconds to obtain the intermittent switching rate. So in the result, we can see from figure 3 and 8 that there is like the denser spikes, number of spikes in the healthy control subject compared to the PD subjects. So we can see that even more clearly in the average result. There is the clear difference on the group effect between the healthy control and the PD subjects, regardless of the test being performed on the experiment. Unfortunately, we couldn't find the test effect using the ISR measure, but we noticed that there is a slight decrease when in the PD subject when they change from the single to the dual test. This might show like deficits on the the balance control of the subject when they perform the dual tasking compared to the single tasking. In summary, we see that ISR can be a good measure to assess the impact of the Parkinson's disease, and further studies are necessary to further investigate the impact of the dual tasking on the intermittent switching rate. And our future work include expanding the number of the subjects and investigate the other approaches to extract the information from the discontinuity to characterize the cognitive test, cognitive effect on the balance. And we also want to adopt this measure on other neurological disease populations such as multiple sclerosis. Yeah, thank you very much for your attention.
Thank you, great talk. Well, we have one more talk in our session. We were able to bring in our next speaker, Wentao Li, who is going to be speaking to us about the underlying structural differences of multiple hip pathologies, resulting in alternate strategies for control of balance during a back squat. And so Wentao, take it away.
Hi everyone, I'm Wentao Li and I'm from UT Austin. So the title of my presentation is Underlying Structural Differences of Multiple Hip Pathologies Result in Altered Strategies for Control of Balance During Squats. There are multiple joint pathologies such as developmental dysplasia of the hip, DDH, and femoral acetabular impingement syndrome, FAI, that influence gait mechanics and overall quality of life. So at the joint level, these pathologies are quite different because DDH is often associated with undercoverage of the femoral head relative by the acetabular and may result in structural injury and instability of the hip. In contrast, FAI is typically considered an abnormal morphology contact between the acetabular and the femoral head as a result of an overconstrained joint through either the cam or the pincer. But commonly, both DDH and the FAI pathologies can lead to hip pain and long-term degradation of the hip, including osteoarthritis and eventual total hip replacement. Multiple studies attempt to highlight biomechanical differences that exist in these two groups during ambulation and non-ambulatory tasks such as single or bilateral squats. Squats require large motion of the hip and used in functional movement screen. Decreased hip kinematics moments as well as squatting depths were observed in persons with FAI. And squats are also destabilizing tasks that require control of balance. However, the mechanisms that these individuals with hip pathologies will not, how they control the balance are not well understood. Therefore, so the purpose of this study was to investigate dynamic balance regulation of the populations with DDH and FAI during bilateral and single leg squats. So given the difference of the hip pathology within these patients, we hypothesized that dynamic balance would be less regulated in DDH and more tightly regulated in FAI populations relatively to the control subjects. So in the study, 9 control subjects and 30 patients performed 3 trials, each of bilateral, left leg, and right leg squats. The subjects were asked to perform a controlled squat as low as they could and use their preferred style for single leg squats, either with their swing leg forward or the swing leg backward. The trajectory of the reflective markers were recorded using a 10-camera Vicon system and processed in Vivo 3D. The dynamic balance was then computed as a whole body angular momentum of A or H using this equation that accounts for the angular motion of all segments. We use the statistical parametric mapping or SPM ANOVA to compare the trajectory of angular momentum of different groups in bilateral and single leg squats. The group average and standard deviation of angular momentum was shown in the figure, and the C lines indicate the significant differences in that area. And the individual with DDH and FAI control their forearm or sagittal plane dynamic balance more tightly than the control subjects. This may suggest a similar protective mechanism that may be used for the the sagittal plane balance. And there are also significant differences of frontal plane dynamic balance, mainly between the DDH and FAI group during the first half of the bilateral squats as the task was initiated. Individuals with DDH had a tendency to allow their angular momentum to move toward their affected line, while the FAI group tend to rotate away from their affected line. But however, there were no differences between the three groups during the single leg squats, potentially due to the different single leg squat styles they use. And these findings may suggest that quantifying dynamic balance during squats could serve as a part of a health screen to help determine FAI or DDA. That's it.
Great, thank you so much. I really appreciate your time. Great presentation. We are going to transition to our question and answer for our first block of speakers. And you guys are doing a great job of putting your questions in the chat. So I'm going to go all the way to the top and ask Eva, who was our first speaker, to address sort of a broader question that I was also curious about when I read your abstract. Why aren't people using a more dynamic MVC? Are there some disadvantages to it, like a setup and an accuracy issue, or is this a resistance to change in the industry?
So I think it's a little bit of both, but mostly there are some disadvantages. So you'd have to collect the dynamic maximum on the same day that you're collecting your experimental data, because you don't want the EMGs to be moved. So that would be one of the limitations, which depending on what your task of interest is, could result in fatigue that will affect your ultimate test. So for our study, we were specifically wanting to look at maximum and sub-maximum back squats. So we needed to collect that data as well. That was part of our protocol. So that's why we were able to use that. And then depending on the task, another drawback is you might not be getting a true maximum. So if you're having them sprint or do sprint cycling, that may not actually be giving you a true maximum of that actual muscle.
I have some more questions about anatomical differences in a back squat and how you would control for that, because you highlighted that in your talk, and I would love to get into that more, but for the sake of time, I'll move on to the next question and I'll hopefully pick your brain a little bit later about that. I muted myself to tell our next question. Our next question is, why is EMG amplitude greater during a dynamic task compared to that isometric contraction?
What we saw for the MVIC is you're holding at a specific angle, and actually the angles that we saw the peak EMGs for the dynamic tasks were not the angles that you're holding the MVIC. So that's certainly part of it. Also, you're often sitting in a chair or laying on a table as opposed to trying to stand up while you've got a couple 100 pounds on your shoulders. So you're going to be having that external load is going to really make you push to get that true maximum, where, you know, effort is really important for MVIC.
That makes sense. Okay, I've got more questions, of course, for you, but let's move on to another speaker's questions, just because we only have a couple minutes left. A question for our sit to stand speakers. For your order of your dual task, did you randomize the single versus dual across those participants? And I think, could you remind us of what your dual task was? It was a serial sevens or a serial counting task, correct?
Yes, so it was counting backwards by 3, starting from a randomized number.
Okay, and then they would like to know if, as this final part of this question, do you think that this could be expanded to the time up and go test, which is growing in popularity in its dual task version?
Yeah, so we actually based our cognitive task from the timed up and go cognitive. So we pulled that idea from there, and we did not randomize, I guess, in the sense that I'm thinking of, maybe the question is asked single versus dual. We did have participants perform their single task and then complete their 3 trials with the dual task following.
And what about prioritization? I have to ask, did they have any instructions to prioritize one or the other?
No, they didn't.
Okay.
Sorry, Sarah. No, they did not. We just gave them the instruction of standing up, sitting down 5 times as fast as possible while counting backwards 5 freeze.
That is a great point. So I'm going to ask a follow-up question for you guys since we're on this topic. Do you think that the impact of that cognitive load would be different in different populations? Could you maybe use this to estimate cognitive deficits due to injury or disease?
So I actually love that question because that's what we're continuing to look at now with further studies. We have more students at Elon that are expanding our study into older adults. And we actually had our first participant come last week, and they did observe a further increase in their time with dual tasking. And I believe based on the numbers, we found that the individual without the addition of the cognitive task, just using the single task, they were not classified as within the fall risk range. And when the dual task was added, they would have been classified based on the 5 times sit to stand guidelines. And so I really hope that this could be continued into other populations. I do foresee us seeing differences among people and how that could affect their prognosis for sure.
Very cool. Thank you. I have more questions for you too, but I'll pick your brains later, ladies. And I do have a couple questions for Phan. Vu, can you tell us how the cutoff threshold is chosen and how does this value have a physiological meaning?
Yes. So for the cutoff threshold, So for the cutoff threshold, we selected the threshold by calculate. First, we calculate. We get the instantaneous frequency series, and then we calculate the standard deviation of that. And we selected the threshold by trying different multiples of the standard deviation. We did the sensitivity analysis. So with, like, for example, we selected the threshold as the 1 standard deviation, 2 standard deviation, or 3 standard deviation. And we see like the trending of the result is pretty consistent, which means like there is still the difference between PD and healthy control. However, like we try to keep that as the to keep the intermittent switching frequency to have some meaning. So we try to select the threshold so that the ISR value will be lying in the range of from 0.5 to 4 Hertz, which was found as the common switching rate in the human. So.
Cool, very cool. So some physiological stuff in there, very cool. Guys, we've only got time for one more question, and I apologize, we're a little bit behind, but as is the normal. I would like to get Wentao one question. We have a question for you. Why weren't all participants required to keep their non-squatting leg forward during the single leg squat? Do you have any idea why the leg squat didn't bring out large differences, or why the double leg brought out large differences, but the bilateral squat did?
I think it's because some of the subjects cannot perform one type of single squat. Maybe so we have to make them using the style they prefer. And the reason why the single leg squat didn't bring large differences because so the angular momentum, the whole body angular momentum accounts for the all body segments moving. So if you use your swing leg in different direction, the direction of that segment angular momentum is on the opposite. So the total would be maybe canceled on average. So that may be the reason. I hope that can answer the question.
Awesome. Yeah, I'm very interested in that measure and that approach. So thank you so much, guys. We're going to pass it off to our next moderator, Antonia, who's going to guide us through the next portion of this this session. Thanks all.
Hi everyone, I'm Antonia Zaferiou. I'm pleased to introduce the next 4 talks, starting with Ross Brancati, who will present time to contact captures declines in postural control following fatiguing activity.
You can all see that? All right, so The Advanced Standard Physical Performance Battery is an established validated test consisting of a few different tasks, including chair stands, balance tasks, and some walking tasks. For the balance tasks, there are 4 stances that the individual must perform, depicted by positions of the feet in these images. So there's the side-by-side stance, the semi-tandem stance, the full tandem stance, and the single leg stance. The participant is tasked with holding each of these stances for 30 seconds, and as long as they can hold them for the full 30 seconds, they will receive a good mobility score, according to the balance portion of the Advanced Standard Physical Performance Battery. There's also this metric, time to contact, which is defined as the time it would take the center of pressure to contact a stability boundary. Physiologically, this metric represents the amount of time it would take someone to make a postural correction in order to prevent a fall. To calculate time to contact, we put retroreflective markers on the feet to calculate the base of support, and we also have them stand on a force plate to capture the trajectory of the center of pressure over the entire trial. This metric, time to contact, is advantageous because it accounts for both temporal and spatial aspects of the center of pressure, whereas other metrics only account for one of these domains. So muscle fatigue is defined as an acute reduction in force and power production, and is commonly experienced in endurance activities, which may impact an individual's ability to control their posture. It's also been a proposed contributor to performance fatigability, which is defined as a normalized metric of performance deterioration in response to a standardized activity. In this case, our standardized activity are these 4 different balance task stances. So knowledge gap is that the impact of balance task stance and muscle fatigue on time to contact has not yet been quantified. So my research question was, are declines in postural control, which are associated with increasing stance difficulty, captured by this metric time to contact? And the reason being is that time, which is the only measure to assess balance in the SPPB-A, does not provide data on how the person is controlling their posture. It purely tells us how long they can hold a particular posture for. And my hypothesis was that time to contact will decrease with increasing stance difficulty and also with the effect of fatigue. So for the methods, we had 4 young female adults with an average age of 34 that were tasked with holding each of the 4 different balanced postures for 30 seconds or until the individual fell. We had them do this within the motion capture space to generate this support boundary, and also stand on a force plate to generate the center of pressure trajectory. We then had each of the individuals walk on a treadmill for 30 minutes, which was previously found to induce knee extensor muscle fatigue in younger adults. And then following the 30-minute treadmill walk, we had them hold each of the different stances for 30 seconds within the motion capture space on the force plate, just as we did directly before the 30-minute treadmill walk. So first off, it's important to note that all of the participants were able to maintain balance for the full 30 seconds. So time alone doesn't really show us any changes in their posture or see if the fatigue protocol affected their postural control. However, this metric time to contact, and specifically the minimum time to contact, does actually bring out some of these differences. And the reason we look at the minimum time to contact is because it represents the minimum amount of time that an individual has to make a postural correction in order to prevent a fall, which is a metric of interest in our study and has been shown to be a metric of interest in previous literature as well. And as you can see from this dot plot on the left, as we increase in stance difficulty from left to right, so from the side-by-side to the single leg stance, we can see declines in this metric minimum time to contact in both the pre-fatigue and the post-fatigue conditions. It's also important to note that there's a statistically significant difference between each of the different conditions. And to assess the effect of fatigue, we looked at effect sizes. There's a nil effect in the side-by-side stance, a very small effect with the semi-tandem stance, and a moderate effect of this fatigue protocol on the single leg stance. So to conclude, time, which is the current measure in the SPPB-A, is not sensitive to changes in postural control. However, this metric time to contact does capture these declines in postural control with increasing task demand. And simple stances, such as side-by-side, are not influenced by fatigue, especially in this young and healthy population. So more challenging stances, such as a single leg stance, should be used if this is going to be assessed in a clinical setting. One of the major take-home messages is that time to contact may provide the necessary data to quantify postural control, which is important, especially in older adults who experience aging-related declines in stability and ultimately who are at higher risk of falling. However, in the future, we must establish clinically meaningful differences in time to contact before they can actually be used as clinical measurements. So I'd like to thank Dr. Kent, Dr. Boyer, and Dr. Miller, the 3 PIs in the project, along with Kate, Charlie, and Aiden for recruitment and processing, and the NIH for the funding, and my contact information can be found at the bottom of the slide. Thank you.
Thank you very much, Ross. Great talk and looking forward to the discussion after. Our next talk is by Michael Christensen, the reliability of minimum detectable change of the margin of stability.
Hello, everyone. My name is Michael Christensen, and today I'll be talking about the reliability and minimum detectable change of the margin of stability. So the margin of stability is a measure of dynamic stability as both construct validity, as it's shown to be altered in populations at a greater risk of falling, and mechanical relevance, as it's proportional to the impulse required to cause a change in stability states. The margin of stability can be quantified as the distance between the edge of the base of support, which for our purposes we'll define as the toe marker, and the position of the extrapolated center of mass. The extrapolated center of mass is the point that considers both horizontal position and the scaled velocity of the center of mass as per this displayed equation, where G is equal to gravity and L is an estimated pendulum wave. And for our definition of margin of stability, negative values indicated that the extrapolated center of mass is beyond the edge of the base of support, while positive value indicated the extrapolated center of mass is within the edge of the base of support. So we calculated margin of stability in two different directions, each a unique point in time. In the anterior direction, we determine the margin of stability at mid-swing, a point in the gait cycle where a trip is likely to occur. And in the lateral direction, we determine the minimum margin of stability, which is a common approach in the literature. So we recruited 15 individuals without impairments to visit the lab for 2 separate visits, roughly 3 weeks apart. And participants walked at 2 self-selected speeds, a preferred speed and a fast speed. So at each speed, we calculated margin of stability values. We then assessed reliability across visits for each condition using ICC values and bland Altman plots. And we also calculated minimum detectable change for each condition. And the minimum detectable change just refers to the minimal change required to determine that a difference is not the result of a variation. And it can be represented by this displayed equation at the bottom that considers 95% confidence interval, the standard deviation, and the ICC value. So before diving into my results, I want to take a brief moment to orient you to the figure I'll be showing. So I'll be using bland Altman plots to represent my data. Here we have title indicating the walking speed and the margin of stability condition. Below it, we have MDC values and ICC values. At the bottom of the plot, we have average walking speed and 1 standard deviation. Along the x-axis, we have average margin of stability across visits. The y-axis, we have differences between visits, with the mean difference represented by the solid black line and the limits of agreement by these dashed lines. And each black square represents a single subject. And while interpreting this plot, we're looking for small limits of agreements that include 0, and our data would be mostly within these 2 dashed lines, as well as a random distribution of data points. So now let's get into the actual data. In this top row, we have minimum lateral margin of stability values. The plot on the left shows a preferred walking speed, and the plot on the right shows a fast walking speed. And for each walking speed, we saw acceptable levels of agreement and an MDC values of just below 1 centimeter for each condition. On the bottom plot, we have anterior margin of stability at mid-swing. Again, the plot on the left shows preferred walking speed, and the plot on the right shows fast walking speed. For each walking speed, we saw excellent agreement and determined minimum detectable changes. So seeing such strong levels of agreement was slightly unexpected, as we didn't strictly control for walking speed, which could have caused the variation in walking speed to directly influence anterior stability, which in turn would have contributed to weaker agreement in this direction. One potential source of error that resulted in less than ideal ICC values in the lateral direction could have been the result of small differences in marker placement between visits or slight deviations in walking trajectory from our prescribed direction. And these results are meaningful as they inform researchers on the changes in margin of stability necessary to determine that a change in stability was meaningful. So in conclusion, from the study, we determined that margin of stability is a reliable measure when assessing stability for individuals without impairments. This is supported by previous literature, such as literature looking at the reliability of anterior stability at heel strike during treadmill walking. In this specific study, the authors assessed within trial reliability and used a different gait event, but still found similar levels of agreement to our study. This is an important consideration, as we can't assume that reliability will be consistent across different points in the gait cycle and when walking at a fixed velocity. And consideration also has to be given to differing definitions of base support or pendulum length. So future work will be focused on investigating the reliability of margin of stability for individuals with disabilities, such as children with CP, individuals post-stroke, or individuals with lower limb amputations. And currently we have a large data set of children with CP who came into our lab on 2 separate occasions to analyze. And I'd like to thank everyone for taking the time to listen to my presentation, and I look forward to your questions.
Thank you very much, Michael. Our next talk is from Onbeshnik. Expectation of gate initiation alters the covariation between the horizontal ground reaction forces.
Can you hear me now? Can you hear me? Yes, okay, cool, thank you.
Yes, we can hear you.
Okay, stability is a critical characteristic of functional human movements. Stability is defined as the ability of the motor system to maintain its current static or dynamic state by rejecting internal and external disturbances. Through decades of research, we know quite a bit about the mechanisms that stabilize steady state human movements. However, it has been long pointed out that the control objective of the nervous system is to modulate stability in a task specific way. Thus, stability is itself a controlled feature of movement. Animals often voluntarily reduce the stability of current state before executing a maneuver, the so-called stability maneuverability trade-off. This trade-off has been studied in fish and birds, but has received less attention in human movements. So our overall goal is to identify whether and in what forms this trade-off appears in human movements. Here, we studied the stability modulation in gait initiation. That is, we study the first half of the stability maneuverability trade-off. And we found that stability modulation exists in gait initiation in a way that facilitates pelvic rotation before initiation. Anticipatory postural adjustments mark the onset of gait initiation, where postural muscles activate to unload the stepping foot. However, the stability of important performance variables, for instance, the center of pressure, reduces few hundred milliseconds before anticipatory postural adjustments. This stability modulation is called as anticipatory synergy adjustment and is defined as a change in covariation of input variables, for example, muscle activations, causing reduction in the stability of performance variable, that is the center of pressure. So we explored if anticipatory synergy adjustment is seen in net anterior posterior and net medial lateral ground reaction forces during preparation of gait initiation while stepping onto a curve. We compared 2 tasks. Participants did not expect to initiate gait, that is quiet standing task, versus expectation of gait initiation in a choice reaction time or CRT task. During quiet standing, the net shear forces are expected to be stable and close to 0. However, to initiate gait, the net shear forces must change. Before the target jumps in the CRT task, individuals expect to change the net shear forces, but do not know in which direction the net shear forces should increase or when they should increase. Reducing the stability of the net shear forces would facilitate their alteration when the target jumps. Therefore, we expected to see changes in covariation amongst the anterior, posterior, and middle-lateral forces under each foot in such a way that the net forces in respective directions would be destabilized when gait initiation is expected. Healthy young participants stood in front of a 4-meter long curve with feet shoulder width apart and with each foot on each force plate. A monitor placed beyond the other end of the curve, as shown here, displayed square targets. Each participant performed 2 tasks, the steady task and the choice reaction time task. In the steady task, participants knew that the square target would remain stationary at the center of the screen, and hence they had to remain standing while looking at the stationary target. In the CRT task, participants expected the target to jump either to left or right on the screen after a random duration, and they had to quickly initiate gait by stepping onto the curve with the corresponding limb and walk till the end of the curve. Each task was performed 15 times. We chose anterior, posterior, and medial lateral ground reaction forces during the steady task and during the period of choice reaction time task before the target jump for the stability analysis using the uncontrolled manifold method. On the x-axis are force pairs along anterior, posterior, and medial lateral directions, and on the y-axis is the stability index called as the synergy index obtained from the uncontrolled manifold analysis. Contrary to our hypothesis, stability of net anterior posterior force and net medial lateral force increased by about 60% when gait initiation was expected as compared to no expectation of gait initiation. Now, increase in net ground reaction force stability means greater negative covariation in force pairs. This could be because both anterior, posterior, and mediolateral force pairs have conflicting goals during quiet standing. For instance, to maintain the net anterior posterior force and net moment about the mediolateral axis, the anterior posterior forces under each foot must co-vary negatively. However, to maintain net vertical moment, this pair of forces must co-vary positively. Our results show increased negative covariation for the choice reaction time task compared to the steady task. This means that while the anterior posterior force pair stabilize the net anterior posterior force, they contribute towards destabilizing the net vertical moment at the same time. This would facilitate pelvic rotation when gait is initiated. A similar conclusion regarding the mediolateral forces is plausible. However, we do not have the center of mass position to determine whether the mediolateral forces create opposing moments about the vertical axis. Our results show changes in the control of ground reaction forces in response to mere expectation of gait initiation, which is in contrast to earlier studies that demonstrated anticipatory synergy adjustments and anticipatory postural adjustments in self-paced gait initiation. Our results can serve as a baseline for evaluating between leg coordination in older adults and assist in identifying mechanisms that lead to frequent falls. Our results can also assist in creating control policies for powered lower limb processes, especially for detecting the intention of gait initiation. And thank you for your time.
Thank you very much, Anbesh. Our last talk of this block is given by Melanie Lott, entitled Rotational Inertia and Principal Axes of Rotation During Dance Pirouettes.
Thank you so much for that introduction. Today I'll talk about rotational inertia in the context of a particular dance turn called a pirouette, shown here. We're specifically looking at 3-turn pirouettes, and we're looking at the consequences for dynamic balance in rotational inertia. So first, a little background and motivation. Rotational inertia, it's a 3x3 matrix, and it represents the distribution of an object's mass around axes of rotation. It's, for any 3D object, there are certain axes of rotation that are called principal axes, even for a strangely shaped object like a person. And what principal axes are, is if the rotation is around a principal axis, then what that means is the angular momentum vector and the angular velocity vector are parallel. And it is a situation where you're in dynamic balance, according to the mechanical definition of it. So when I use the term dynamic balance, that's what I mean in the context of my talk. So if you're spinning around, an object is spinning around one of these principal axes. So for an object like a symmetric top, these principal axes are relatively straightforward to find. One of them, so it's labeled as E3 hat. You can think of this as the spin axis of this top. That's the principal axis. It's the symmetry axis, in fact. So if I rotate the top around that E3 hat axis, then it should be dynamically balanced. The other two principal axes are mutually orthogonal to those. They're labeled as E1 hat and E2 hat in this figure. And you can think of those as the topple axes for this symmetric top. Since the top hat has a symmetric mass distribution, then the moment of inertia around these two topple axes will be equal. But our question is, what for a dancer that's spinning in a pirouette? What are these principal axes of rotation? In which case, if the dancer were to rotate around a principal axis, they'd be dynamically balanced. Otherwise, if you rotate around an axis that's not a principal axis, then the object will experience a wobbling effect. So we had two hypotheses that are related to this that we were investigating. One of those is that for successful pirouettes, ones in which the dancer would complete the 3 rotations before landing, versus unsuccessful pirouettes where the dancer landed the turn early, we were hypothesizing that there would be closer alignment between the spin principal axis, and if I were to connect a line between the center of mass and the base of support, that those would be more closely aligned for successful pirouettes than unsuccessful pirouettes. And the other hypothesis was that those two topple moments of inertia for the dancer would be equal for this pirouette position, even though clearly the dancer, the pirouette position is not bilaterally symmetric. But we were testing these two hypotheses. Our results from motion capture of, we had 6 dancers who performed 3-turn pirouettes, 5 different trials of them. So here are our results for the average moments of inertia around these 3 different axes. So from here, you can see that well within experimental uncertainty, the topple, these are I1 and I2 are the moments of inertia around the 2 topple principal axes, that they're equal well within experimental uncertainty, which might be a little bit surprising since a dancer is not actually a symmetric object. But this was expected from an earlier theoretical analysis. And then the spin moment of inertia over here, there's a lot less mass concentrated close to the axis of rotation in this case, so it makes sense that the spin moments of inertia are smaller than the topple moments of inertia. And then our other question about the alignment between the center of mass and base of support line and this spin principal axis. Here you see a graph of the center of mass. So if I were to draw a line connecting the center of mass to the base of support and measure the angle that makes with the vertical, I'm calling that the center of mass base of support angle, and that's on the y-axis. And on the x-axis is that third principal axis angle with respect to the vertical. And this is for all dancers and all trials and all times for this turn phase of the pirouette. And what you see is, so there's a highly significant correlation between the center of mass base of support angle and that third principal axis angle. And in fact, so the solid line is, it's a line with a slope of 1. So if all of the data fell on that line, then they would be equal for all times. The actual fit is this dotted line with a slope very close to 1. So in fact, for all dancers, this was for both unsuccessful pirouettes and successful pirouettes. It shows that those the 2 conditions, so the static condition for balance of the center of mass and base of support, it makes a straight line with respect to the vertical, and the condition for that dynamic balance that I mentioned earlier, spinning around the principal axis, can both be met simultaneously. But it changes with time throughout the pirouette, and for all of these dancers, the angle that it made with the vertical ranged between around 0 and 6 degrees with respect to the vertical. So in conclusion, our findings that the topple moments of inertia were equal seem to indicate that mechanically there's a lack of preferred topple direction just based on the mass distribution of the body. And this finding that the spin axis, principal axis, and the center of mass base of support line are roughly the same seems to indicate that the alignment did not predict the success for these, at least for these 6 dancers and for this particular style of pirouette. But it would be interesting to study other styles of turn where maybe there's a less sort of symmetric mass distribution of the body than in this case of the standard style for a dance pirouette. So I thank you for your time and look forward to any questions you may have.
Thank you very much, Melanie. I look forward to talking to you more about pirouettes, one of my favorite things. So let's open up for some questions. I chose 1 question per talk. So this is for Ross from Sarah Rolker. Very interesting talk. You mentioned that 30 minutes walking is fatiguing for the knee extensors in younger and older populations. How important are the knee extensors relative to other lower extremity muscles to controlling postural stability during each of the stances? Are there alternative fatiguing protocols that may be more fatiguing for young adults and or target those muscles that are important for controlling postural stability in these stances?
Well, I think all muscles in the body are involved some way in controlling your posture, all the way from your neck down to the soleus and the gastroc. But I do think that the knee extensors are important in controlling posture, but my guess would be that the soleus and the gastroc would also take a lot of the weight of controlling someone's posture, and even more so in a stance other than the side-by-side, so maybe in the single leg stance. And in terms of fatiguing protocols, I think that it would be interesting to test more of a localized fatiguing protocol, such as a calf extension, maybe trying a leg extension or hamstring curl, or a fatiguing protocol just targeted at the gluteus as well, and looking at how those different fatiguing protocols actually impact an individual's time to contact.
Thank you very much, Ross, and please check out the other questions in the chat. We're Michael from Maddie Major, it seems there may be some presence of proportional bias or dependent on average and margin of stability. Did you quantify this? And if you agree, why might that exist?
So thank you for the question. We do not specifically quantify this, but I think this might be the result of using like self-selected walking speeds. So perhaps for those who walked at faster walking speeds, we might have seen greater differences between visits and walking speed, which may have resulted in larger margin of stability differences between visits, but that would be something that we'd have to follow up on and analyze.
Thank you very much, Michael. For Melanie from Satya, isn't rotation about the intermediate moment of inertia axis unstable, the so-called tennis racket theorem?
Yes, thanks for that question. So, and for the intermediate axis, that would be the axis where if we kind of rank the size of the moment of inertia, the first axis would be the axis around which you have the highest moment of inertia, to the third, which is where you have the least moment of inertia. So in this case, it would apply where the intermediate, so the second moment of inertia, is in between the two, in which case if you have rotation around that axis, then yes, it's unstable in the sense that if you kind of move away from rotation around that axis ever so slightly, it will accelerate away and rotate around the different axis, principal axis. In the case of a symmetric top, since their I2 and I3 are equal, then that effect wouldn't really apply. So, so for the symmetric top or the dancer, in the case that if those moments of inertia are really close to being equal, then it wouldn't quite apply as much in that case.
Thank you very much, Melanie. The last question for Anvesh from Louis Antonia Nolasco. Great talk. Did you find any patterns in the roles played by dominant and non-dominant limbs for modulating stability during gait initiation in your study? Did you control for which leg they initiated gait, or was this self-selected?
Yeah, that's a good question. So we did not control for that because it really doesn't matter to our analysis or the question that we are asking. So we restricted our analysis to the portion where participants were standing stationary. So for the steady task, for the entire duration, they remain stationary. But for the CRT task, before the target jumped, participants remained stationary for some duration. So our analysis was restricted to only that portion. So for that, it doesn't matter whether people are left or right dominant. And we kept the duration constant, so from 2 to 4 seconds as our analysis window, and that was consistent across both tasks.
Thank you very much. And I thank all of the speakers and participants for their thoughtful questions and answers. So next, Peter will present or introduce our final 4 talks for today.
Thank you. And I want to thank all the speakers so far. And again, remind people that if your question was not answered, we do have room in the spatial chat. We're in the Murray spatial chat room after this. So please meet all of our speakers there. Okay, now moving on to our final block of 4 speakers. Our next talk will be on modeling the lean release with surface translation and surface translation perturbations with an inverted pendulum on a skid for forward, sideways, and backward loss of balance directions, presented by Gaspard Diotalevi.
I had an issue with my mic. Thank you for the introduction. This is a very long title to say that I model people falling in every direction. I acknowledge my thesis advisor as well as the Université de Sherbrooke for funding. My work takes place in the context of the perturbation threshold line method, which plots the angular position and angular velocity at reaction time at the threshold of balance recovery. It seems that no matter the postural perturbation, if a participant is to cross a common threshold, then the fall is unavoidable. Likewise, If he remains under this threshold, he is likely to recover his balance. At least, this is what the perturbation threshold line method suggests based on experimental trials and theoretical modeling of lean releases, surface translations, waste balls, and the combination of those perturbations. It has been shown that this threshold moves towards the origin of a graph with age. So far, it has been studied for forward losses of balance. But what about backward and sideways losses of balance? Recently, Chebby and Smithers have measured this threshold for forward, sideways, and backwards losses of balance with young adults subjected to lean releases, surface translations, and their combination. My master's research project was to use our model and prove that it can accurately predict the outcome of a loss of balance for forward, sideways, and backward losses of balance based on those experimental trials. This model is a simple inverted pendulum on a skid. As the participant simply falls passively during the first hundreds of milliseconds, a single segment pendulum is enough to produce satisfactory results. The different postural perturbations and their combinations can be simulated by adding a force at the waist, F1, pulling the rod, F2, or simply leaning the rod forward using the initial conditions. The only participant-specific values that we require are the height, weight, and reaction time, which makes it fairly easy to model about anyone. Here is a showcase of the results in all three losses of balance directions. In light colors, Chebby and Smithers have shown that the perturbation threshold line moves towards the origin of the graph for sideways perturbations, and even more so for backward ones. In dark colors, you can see that my model produces quite similar results. To illustrate this better, I will now zoom on the sideways plot. Once again, light colors stand for the experimental trials and dark ones for the modeling. Considering all directions together, it is true that results are significantly affected by perturbation, direction, and their interaction. However, compared to the experimental perturbation threshold line standard deviation, our model has been found to produce smaller errors. In fact, those errors are 2 to 3 times smaller than the experimental variability on average. Our lab's prior study had shown that this simple inverted pendulum on the skid could accurately predict the outcome of lean releases with surface translations, and surface translation across all age groups for forward perturbations. My work has now shown that this very same model can be used for young adults to predict the outcome of sideways and backward losses of balance. This is important because the direction of fall is a major risk factor for fall-related fractures. Furthermore, this model can be used to optimize future experimental protocols with middle-aged and older adults, for it reduces the need for a costly, tiring, and potentially dangerous trial and error with participants to determine the optimal perturbation amplitudes to use. But this will be the job of another graduate student after me. My next challenge will be to try to adapt this model to model slips as well, and to produce an experimental setup to test this improved model. Thank you for your attention.
Okay, thank you, Gaspard. We are gonna now move on to the next talk. So I'm happy to introduce Virginia Liang, who will present her study on auditory cues can elicit anticipatory adjustments for posterior perturbations after short training.
Okay, thank you for the introduction. My talk is also about the postural perturbations. So it's about using the auditory cues to help to the participants to elicit the anticipatory postural adjustments for posterior perturbation. So a little bit of introduction. So when people see a postural perturbation, such as a hit or bump, which cannot be avoided, they use the central nervous systems to employ anticipatory postural adjustments to make feed-forward mechanisms to minimize the postural disturbance that could from these external perturbations. So APAs involves the activation or inhibition of the postural muscles that would oppose the expected balance disturbance. On the other hand, compensatory postural adjustments or CPAs are feedback mechanisms that make postural adjustments after the actual impact. So strong APAs could reduce the demand for CPAs after the impact. However, all those the generation of APAs majorly relies on the visual informations. So when the external perturbations coming from the back, we do not have these protective mechanisms to prevent or to diminish the postural impact. So our previous works show that when using an auditory cue or beeping sounds could help the young people and older adults to generate the APAs for frontal perturbations. So right now we're thinking of using the same logics to help them, to train them to develop anticipatory postural adjustments for posterior perturbations. So we recruited 10 young adults for these studies, and then they're asked to stand straight on the fourth plate and be prepared for perturbation coming from the posterior side, from the back. And the perturbation is created by swinging pendulums. And we also add additional 3% of the body weight to the pendulums to add a little bit more perturbations for the adults. And they are instructed to stand straight on the fourth plate and then stand still with the external perturbations without making additional corrective steps. And then we are also recording EMG activities bilaterally from the postural muscles and also the center of pressure data in the anterior posterior directions. So during the data collections, we first using the pendulum hits to hit them for 5 times. So it's basically just a blind hit. And then during the training conditions, we included 10 blocks of 5 trials. And then we also give them beeping sounds to instruct them of when the pendulum is released. And they're encouraged to connecting the beeping sounds with the events of the pendulum hit. And after 5 minutes of rest, we also have a testing period, which includes 5 trials of the hits with the same beeping sounds or the warning sound. So an accelerometer was attached to the pendulum to identify the time of impact as T0. We also analyzed the EMG integrals and normalized them for each EMG sensors. We also used the one-way repeated measure ANOVAs were conducted on the normalized EMG integrals at 2 epochs for each muscle, and also on the center of the pressure displacement at T0, which is the APA center of the pressure displacement, and also its peak values after the impact signify the center of the pressure displacement at the CPA phase. So here are some of the results. Oh, it keeps running. So here are the results. So those graphs are shows the integrals of the representative muscle biceps femoris and also the center of the pressure displacement. We can see that there is minimal muscle activations in the APA phase, and also there is no center of the pressure displacements during the APA phase during the baseline conditions, shown as the striped orange bars. So as a result, we can see huge muscle activations during the CPA phase and huge center of the pressure displacements during the CPA phase. And then during training, we can see a gradual increase of the APA muscle activations during the APA phase and gradual increase of the center of the pressure displacement during the APA phase. So as a result, the demand for the muscle activations during the CPA phase would decrease, so as the displacement for the center of the pressure movement. So the conclusion is that after, well, sorry, it keeps jumping. So the conclusion is that after a short period of training, young adults can learn to generate anticipatory postural adjustments patterns relying on an auditory cue for otherwise unpredicted postural perturbations. So our further studies will explore the feasibility of implementing such training methods on more dynamic settings, such as when people are walking, and also in individuals with balance problems, or in older adults that have a higher risk of falling. So thank you for your time and attention, and here are my contact information if you have further questions. Thank you.
Great. Thank you, Virginia. That was an excellent talk. And again, please post your questions in the chat. We're going to move on to our next speaker, who is Chase Rock, who is going to be presenting locomotor adaptation in hypogravity relies on a centralized control architecture.
Hi, thanks everyone for coming. It's a little bit different from the other talks that have been going on, where people are talking about what's going on while someone's touching the ground. My talk will be actually what's happening while someone's airborne. So if we look at someone who's about to experience a fall and then drop them from a height, they'll actually activate their muscles prior to they hit the ground. So if we're looking at the soleus or gastroc, for example, it might activate about 100 milliseconds before they hit the ground. And this helps to kind of pre-stiffen the joint in anticipation of hitting the ground to help mitigate those forces that you experience upon landing. But one interesting thing is that it doesn't really matter what height you drop them from, those muscles always activate about 100 milliseconds prior to ground contact. So this is our first clue that there's kind of a prediction going on that's based off fall height or fall time that your body's doing in order to appropriately pre-activate these muscles. There are some other studies that use blindfolds and look at people who have disrupted other senses to show that this is a largely predictive behavior. So what I presented last year at ASB was if we did a low gravity or hypogravity training session, did this prediction change after coming out of that hypergravity simulation? So did we update people's ability to predict when they hit the ground? And the short answer is we think so, yes. So looking at this figure, this is pre-activation onset timing for the lateral gastrocnemius. And I'm going to show some other muscles in a second. But we have pre on the left and post on the right. And what we see is a reduction when we go from prior to hypergravity training to following hypergravity training. And that trend stayed for all of our muscles. It was a significant difference in 6 out of the 8 muscles we studied. And this got us thinking about what is actually doing this adaptation. Is it the legs? Is it the brain? Is it everything in between? And the first way to test that is to see if what happens in one leg, and if you do this in one-legged jumping, does that hypergravity training transfer to the other leg? So that's what I'm going to be talking about today, is to determine if hypergravity adaptation is limb specific or is due to more generalized control mechanisms. And if they adapt to hypergravity on one leg, will the other leg adapt? And our hypothesis was that yes, it would. So here's a little bit about what we did. We had 10 subjects go through almost the same exact protocol, except they did it twice. And so the protocol includes jumping at normal gravity for 10 jumps, and then going to do 50 jumps in hypergravity where they're either switched to the opposite leg or stuck on the same leg. And then they did some post jumps where we tested the trained leg or the naive leg. And so each person did both of these. It was a randomized order. And then we looked at the results for both of those conditions.
Go.
There's the person jumping on one leg. So what we found is that our results look really similar to our two-legged jumping results, regardless of the experience of the leg that we were testing. So on the left here, we have the one leg that went through the hypogravity training protocol. We see reductions kind of across the limb. But then on the right side, if we look at the hypogravity naive leg, so this is the leg that was held up during the one-legged jumping in hypogravity, it still shows these adaptive after effects, even though it didn't perform any of the jumps in hypogravity. So our conclusion is that hypogravity training on one leg induces muscle activation onset delays in both the experienced and naive leg. So hypogravity adaptation involves an updated prediction of gravity that isn't limited to the limb. So it's not limb specific, it's more of a generalizable control strategy. So the neuromuscular system must use a generalizable representation of, in this case, gravity, a physical constant, to achieve successful motor control. Thanks for listening. This is my team, and I look forward to your questions.
Thank you, Chase. We're going to move on to the next talk. This will be presented by Lindsay Llewellyn on the detection of different fall types in healthy young adults.
Okay, can you see my screen?
Yep.
Awesome. Okay, so hi everyone, I'm Lindsay and I'm a graduate student at the University of Texas. And I'm here to present my research study titled Detection of Different Fall Types in Healthy Young Adults. Losing a lower limb changes your life dramatically. After an amputation, daily activities like maneuvering around furniture or climbing into bed become extremely intimidating tasks. Individuals find it hard to maintain balance and falling often becomes a reality. And as we know, falling can be dangerous. Although if you can obtain help quickly after a fall, you can lower the consequences of falling. Fortunately, many automatic fall detection systems have been developed. These body-worn sensors have been designed to automatically detect falls and connect individuals to help in an instant. So how do these work? Typically, these sensors record linear accelerations, angular velocities, and even magnetic fields. Then an algorithm uses these signals to differentiate between normal activity and an actual fall. The graph on the left shows an example of an accelerometer signal during walking. This signal looks like it repeats about every 100 samples as the subject enters another stride. This should be classified as normal activity. And the graph on the right shows the signal during a fall. This signal reaches a much higher peak acceleration value and should be classified as a fall. For an amputee, these fall detection devices can be conveniently attached to the prosthesis. However, it is not clear if these sensors can detect a wide range of fall types whenever they're placed on the lower portion of the leg. So the purpose of this research is to investigate how accurately algorithms can detect different fall types with a sensor placed on an individual's shank. For this study, we placed IMU sensors on both shanks of 30 healthy young adults. They completed several activities involved in daily living, like walking and turning around. Then subjects completed near falls, where they walked until their foot struck a pad and then they recovered from a stumble. Then they completed two types of simulated falls called trips and lateral falls. For a trip, subjects walked forward or backward until their feet impacted a fall pad and they fell. For lateral falls, subjects stood next to the pad while a lab technician pushed them over. And then for data analysis, we used the data collected from the IMU sensors to develop the fall algorithm. First, we divided data into half-second intervals and categorized these intervals as a fall window or an activities of daily living window. Next, we computed several variables called features within the half-second interval, like mean and standard deviation. Then we split the data into training and model verification data sets. We used the training set to develop 3 types of machine learning algorithms using the MATLAB classification learner application. We included a support vector machine with a cubic kernel, k-nearest neighbor with weighted dimensions, and a bag decision tree ensemble. Then we used the algorithms and the model verification data set to investigate how well each algorithm was able to predict the fall. A fall was identified when 2 or more adjacent windows contained a fall label and was correctly classified if this occurred within the duration of the fall. And fall detection accuracy was defined as the number of correct classifications divided by the total number of actual falls. And so here were our results. We discovered that forward trips had the lowest fall detection accuracy. The detection accuracy ranged from 63.3% to 81.7%, depending on the algorithm used. And so when falling forward, participants can protect their body with their hands and knees, acting to reduce the acceleration on impact. So this makes sense. In contrast, lateral falls with this sensor placed on the inside leg had the highest fall detection accuracy. The K nearest neighbor algorithm reached a detection accuracy of 100%, while the other algorithms reached an accuracy of 96.7%. And so during a lateral fall, individuals fall towards their side, and the inside shank is often the first part of the body that impacts the ground, potentially making these falls the easiest to detect. So in conclusion, fall detection accuracy is not the same for all fall types and classification algorithms. This result suggests that future studies should work to improve detection of forward falls by potentially testing out different algorithms, exploring different features, or even placing sensors in different locations. And additionally, we should validate these results on individuals with a lower limb amputation. I want to gratefully acknowledge the financial support from the Department of Defense with this project and thank Dr. Neptune, Dr. Pugh, Dr. Werdeman, and the members of our lab for their support. Thank you.
Thank you, Lindsay. We are a little bit running low on time just because we got a slightly late start. So we're going to try to get through enough questions here. But again, we can always go to the spatial chat at the end of this session to answer or to ask any questions that we don't get time to. So the first question here is going to go to Gaspard. It says, very interesting talk. In the experimental trials, did the participants always know which direction the loss of balance would be? From the video you showed, the body is pre-leaned in the direction of falling. Could reaction times be artificially fast in these tests?
The short answer is yes, they did know in which direction they would fall. But the thing is, for lean release trials, the participants are always leaned in the direction, so you can't really make them blind to the direction of the fall. Even if you try to blindfold them or blast music through headphones, they will feel that they are being leaned in a direction. So they will always know what is going to happen. We should try to make them oblivious to the direction of the fall for surface translation trials, even though it would require a more expensive experimental setup. But the thing is, our model is very sensible to the reaction time. So the fact that we still have very close results between the experimental trials and theoretical modeling suggests that even if the participant is able to predict and anticipate a fall, the reaction time is probably not that much underestimated.
Great, thank you. Next question is for Virginia. Very interesting work. Did you experiment at all with analog signals, like a tone that was proportional to impact distance versus the single tone that you ended up using in this experiment?
Well, the short answer is no, but thank you for the question. That is really an interesting dot. So right now we're just experimenting on the different directions of the pendulums and how people react or build anticipatory posture adjustments based on the direction. So what we did is when the pendulums are coming from the front and coming from the back, which is this work. And also I do have a poster later today in the poster sessions that are discussing what would happen if the pendulum coming from the sides, whether those reactions would be directional, whether there's a directional effect on that. But thank you, that's really a great thought.
Thank you. Next question is for Chase. Fascinating, actually, we're gonna go, this question from Chase from Roger Anoka, is the pre-activation delay influenced by the intensity of the subsequent contraction?
That is a pretty insightful question. And yeah, let's me talk about kind of how landing happens. Is all these muscles are extensors, so they're all kind of doing a similar function for landing. So from jump to jump, person to person, a different combination of muscles could be used to land. So sometimes one muscle doesn't even really get activated for landing, so it doesn't really pre-activate. We haven't done the analysis you're talking about where the pre-activation timing linked to the magnitude, but we did look at the post-landing magnitude for short, medium, long latency response and didn't find a pre-post difference, but might go back and do what you're talking about, which is to see if that muscle was used for landing, does that impact its pre-activation timing? Great question, thanks.
All right, and we are at 12:30, but we're gonna get one last question in here for Lindsay that says, great presentation. How do you think these results will translate to people with lower limb amputations? Even though you put the sensors in the shank or calf, non-amputees have the ability to actively move their lower leg, whereas this is more difficult for prosthesis users.
Yeah, so great question. And actually we have data from amputees that have fallen as well. So hopefully I'll have this answer to you soon. But I expect that a person who's an amputee with a prosthesis, the fall detection accuracy will probably improve just because the prosthesis is more rigid. And so I would expect that that would be a little bit easier to detect with an IMU placed on their prosthesis. So I hope that answers your question.
Great, thank you all. Thank you to all of our speakers and to the fantastic audience that we had here asking some very insightful questions. I'll remind everyone to please go to the spatial chat room. We can continue these conversations in the Murray spatial chat room. To all of our speakers, I would recommend you download the chat. I have downloaded it and will send any questions that might have been unanswered to you. But that will also help you understand some of the questions that we weren't able to get to quite yet. So again, thank you to everyone, and I hope everyone enjoys the rest of virtual ASB 2021.